A case of a male patient, 63 years old. He complains of yellowish discoloration of his skin and sclera. CT abdomen shows pancreatic head mass with CBD dilatation. The patient is not fit for surgical operation as he has comorbidities. ERCP in November 2019 was done with failure of scope to pass to second part of the duodenum due to mass infiltration. PTD was done with insertion of external drain. The patient is for duodenal stenting plus EUS hepatico gastrostomy.
Là, ils ont.
Ouais,
Debout, là. Qu'est-ce que...
We are on live now?
Ah.
Okay, good
Hello.
morning,
Oh, oui.
everyone.
Hello.
Welcome back for this second day of live endoscopy. So it's my pleasure to introduce the idea with this case, with the whole team is here, with our anesthesiologist, Mektab. Also we have Selma and her colleague who are there for and Hania, the nurses team, and of course I'm working under the close supervision of the Egyptian doctor, Dr. Khaled. And as you see in my right hand, our friend Professor Giovannini. So it's a situation of this patient is a stricture at the level of the duodenum, as you can appreciate already from the endoscopic point of view, and probably thanks to the tube that was placed percutaneously, there is already some flow coming from the bile. So I was using a colonoscope from Fuji here. It could be of interest here because sometimes when you have a very highly decompensated or very heavy decompensated stomach, it could be of use to have a longer endoscope. So the main idea here is first to go with a catheter in order to have a delineation of the stricture before to decide the length of the stent that we will place. So I'm just advancing a catheter inside the therapeutic channel.
Yeah. It's a little bit short, the catheter.
The catheter is probably a little bit short because I'm using the colonoscope. So may I have the X-ray and then fluoro? Okay, could you try to inject the contrast?
Remove the wire. I think it's very important to delineate the length of the stenosis. Because for the choice of the stent is very important, because if it's too short or too long, this can induce some problem after the.
You saw the passage? Okay.
It seems that it's a short stenosis.
Yes, it's a short stenosis, then a short stent should be enough. So now I will ask you to go with a wire. So you remove, a wire. You will insert the wire into the stent. May I have the fluoro?
And what is your choice here? Here it's probably a short stent.
Yes, it will be a short.
Transpyloric.
And I will leave it transpylorically. In fact, the strategy for this patient is to perform an hepatico gastrostomy in order to drain the bile duct. So for here, I will place a short. So yes, you get through with the wire to place a short duodenal stent that will be transpyloric. So Selma already reached with his guide the distal part of the second duodenum. So now I'm going back a little bit, and we will make the exchange, and I will take the 9 centimeter duodenal stent. I was from Cook and the evolution. So I'm going back with my catheter.
I'm a little bit afraid for the EUS hepatico gastrostomy, because if you see, you have some air now in the bile duct.
I will try. Yeah.
And this can induce some difficulty.
It can be challenging. I'm sorry.
No, that's life. That's life.
Okay. Yes.
You should inject water, not contrast. saline, but no contrast.
Yes,
because-
to overcome that issue, we will inject saline, and I will try to suck all the
No,
air
no,
before
it's not so,
to
impossible
but
to
the air of
suck.
the stomach a little bit. Okay, so yes. So I stay in a stable position first to insert the stent, and then I will go back to the antrum to before to deliver and deploy the stent.
Ah,
So that's the other
I
option.
will.
Instead of performing a gastrojejunostomy, as you saw yesterday.
Excuse me, sir. What is the diameter of the catheter you used before
But
introducing
normally the idea is to assume that you will have a biliary drainage before to place a duodenal stent.
Sir, there is a question. What is the diameter of the catheter you used?
I'm not sure
before?
that there is a question coming from the audience, or
Yes. What is the diameter of the catheter you
so
introduced?
Selma is preparing the evolution stent, which is quite easy to deliver,
Hello?
as you know.
Can you hear you over there? Dr. Ragab, can you hear me?
Okay. Yes.
Professor Daniel, can you hear me?
You are not online? You're not sure that we are online. So, okay, I will wait for. No. Okay, it's okay, you can.
We're not sure of what.
دكتور رفاعي هم مش سامعين دكتور رفاعي؟
No?
I think so.
دكتور رفاعي هم مش سامعين؟ سؤال واقف
Change
بس.
the room?
Okay.
Professor Daniel,
Ah, okay.
Professor Giovannini.
Yes, so we
So
have
can
to-
you hear us
May I
now?
have the floor? Okay, we lost our guide. It's a short wire.
Ah.
Okay.
Ouais, si tu pousses, ça
إيه
fait
اللي
rien.
حصل؟
Okay, may I have the
X-ray,
floor?
please.
X-ray. Could you engage your... No.
Il n'est pas passé le guide.
No.
Anyway, Dr. Mahmoud, it's a standard ERCP catheter that passes
So here I'm
point two
afraid
35
we
inch
lost the
guide
wire.
the jack
Oh,
guide
no,
wire.
it's,
as
all,
you
it's,
say.
it's again
So I think
in
it's a
through the
standard,
stricture.
it's a standard one.
So I'm advancing the stent. In my therapeutic channel of this colonoscope from Fuji, and then just advancing it slowly, so you realize that now I'm just in front of the pylorus, advancing the stent into the duodenal lumen
And there is-
until I will see the end, the
yellow
proximal
marker.
and the yellow marker of the proximal hand of this duodenal
Keep
stent.
floor on, please.
So you can appreciate now the yellow marker. I have to get back a little bit here, and I will ask to Selma to try to deploy. And as you can see that there is a two position on this system, one to deploy the stent and another one to retrieve it if it's necessary. So you can start to
X-ray,
deploy.
please.
Okay.
X-ray, X-ray.
Could we? Yes. Okay. So now stopped. Could we see the opening of the stent on the X-ray? Wait. Okay, you can go over. Yes, go ahead. Next.
I think this is
Hey
important.
guys, can you hear us
Not
over there
to see the
in the
yellow
room?
mark. Can you maintain the yellow
The
mark,
mark,
in, the, in
it's
your working
almost,
channel, huh?
almost, yes,
Yeah.
to be sure that there will be a
And
a
you
full
pull back the
but,
catheter because
exactly.
the stent has tendency to go
to,
in.
to go inside the stricture.
The stricture, yeah.
So I'm still pulling. So normally at the end she has to remove a security flange
Wire.
here and wire, and then she can deploy the stent almost completely now. And I'm still pulling on the outer catheter. And so normally in few seconds it should be done. Okay.
Perfect.
Okay. So we
Perfect
have a full deployment just at the level of the pylorus, and then we are happy like that.
Yeah,
So
yeah.
now that we can remove everything, but we still have some work in order to try to have a drainage of the biliary duct.
Yes,
Okay.
we will try.
I will try to suck the air as much as I
Yeah,
can.
in the stomach. Yes, thank you so much.
Hello, Professor Valiro. We have to move to another room. And
No,
come
I
back
don't
to
think
you.
so. I don't think it's necessary.
No.
Sorry if you don't hear me. Can you hear me now? We have to
Is
go
it
to
clear
another
for
room
you?
and come to you back for the hepatico gastrostomy.